Bingo! Hey everybody, Ray Stahlman here. This is Dr. Russell McKissick. We're back. It's now Monday, not Friday, but it still is the Doctor's In Live with TOA. Again, I'm Ray Stahlman, your host. You may notice that the environment's a little different, and that's because we are in our Murfreesboro office, and we're probably going to be down here for a while. I'm starting to see patients down here on Mondays, and I thought I'd be able to take the opportunity to start visiting with a bunch of our colleagues down here who would otherwise not be able to get up to Nashville on Friday because it's a 45-minute drive. So Dr. McKissick, who's been with us for a very long time, he's now one of our senior guys. Hard to believe.
Doesn't seem like that, yeah.
But he's first on the list. Again, as always with these episodes, please make sure you understand that while we're both fellowship trained and or board certified orthopedic surgeons, we're not your orthopedic surgeons. So please consider this information for educational purposes, informational purposes, maybe a little bit of entertainment purposes, but don't consider this medical advice. If you have a problem, particularly with what we're going to be talking about today, which is the anterior cruciate ligament, give us a call. Go to our website, toa.com. Wherever you are, we're around. We have experts in all areas of musculoskeletal care that can give you some good advice that you can count on. So again, if you have problems, let us hear from you. Anyway, without further ado, first off, so I don't forget, we're going to be kind of sporadic for the next few weeks simply because of the holidays. We were a little sporadic before because of the holidays. I got COVID. Don't ask. But first of the year, we're going to be revving it up pretty much routinely. I think we're going to start with Mondays until we exhaust enough of the folks in the Murfreesboro office that they get sick of me, and then we'll go back to Fridays, probably switch every quarter for a while. So just look at our social media posts, Facebook, Instagram, and whatnot, and we'll announce that. But for right now, we're going to stay in Murfreesboro. So without further ado, this is Dr. Russell McKissick. I'm not going to proclaim to know anything about him because I don't want to make any mistakes. I want him to tell you about him. But we're going to talk a little bit about anterior cruciate ligament and what that means. So, Russell, good to see you. Thanks for being here.
Yeah, appreciate you having me. Yeah.
So, tell everybody, that's the everybody.
Yes, everybody.
There's probably 6 people out there.
That's right, yeah.
But that's okay. Carlos, if you're out there, hey, buddy, tell me a little bit about yourself.
Sure.
So let people understand kind of what your background is, what your interests are, that kind of stuff, and you and TOA and your career.
Great. Yeah, it doesn't seem like it, but I've been here since 2007, and been here in the Murfreesboro office since I got started. Originally, it was 2 separate offices, then we joined together, and then joined to this building here that we have near the medical center, which has been great. Before I came here, I did a residency and fellowship in San Antonio, Texas, doing orthopedic surgery there, and did an extra year of fellowship in sports medicine and total joints. And I really have a passion for taking care of the athlete. Since I've been here, myself and Dr. Jordan, we help take care of, and our other partners here, help take care of MTSU. Usually on every Friday night, I'm on the sideline of a football game somewhere, and so yeah, that's it. I mean, started here at college at Lipscomb, then medical school in Memphis, then down to San Antonio for 6 years, and then here for 13, which seems crazy, and just to love being in Murfreesboro and love serving the people here and taking care of our athletes on and off the field. So.
Awesome. Yeah, I can't believe it's been that long.
Yeah.
I mean, I've been 25, and I can't believe it's been that long. Right. But anyway, so we're going to talk today about something that's near and dear to my heart because I had my ACL reconstructed when I was a chief resident way back when. And so give me an idea. I'm sure everybody's heard of an ACL or an anterior cruciate ligament. If you watch any NFL or college ball, you've heard those terms. Tell us what it is. What is the ACL?
Sure. So the anterior cruciate ligament is a ligament in the middle of the knee. It attaches the thigh bone to the lower leg bone or the tibia bone. And what it does is it helps prevent or decrease translation or this moving the 2 bones back and forth. I'm doing my hands like this because this is the test I do to check to see if you've torn your ACL or not. But that's the main thing that it does. And so that's the feeling you have when you have a torn ACL, is that the bones shift on each other more than they should.
Well, how do you injure an ACL? What happens?
Yeah, there's a couple different ways you do it. I mean, there's the sort of non-contact injury, which you may have seen. You mentioned NFL, see it on somebody planting their foot and turning, and their knee just kind of gives out on them. So usually the knee is kind of in an extended position rather than a bent position, and what happens is the thigh bone kind of twists on the tibia bone, the lower leg bone, and then tears the ACL. The other way is a direct trauma. So whether you're in a car accident or your knee gets taken out by another football player or something like that, then that's the other way you tear it, in addition to other things.
So I'm not a collegiate or professional athlete, but I tore mine skiing.
Yes.
And it was my foot got stuck in deep, heavy snow, and my body twisted around my foot.
Exactly.
It was a very slow, non-violent thing, but I knew within 24 hours, I knew what the problem was, because my knee blew up like a raging basketball. So I remember that vividly.
Right.
So symptom-wise, if somebody injures their knee, kind of what would be the symptoms that you would think of that they might complain of that would point you to think that they have an ACL?
Sure.
Injury?
Well, you mentioned one of them, and if you have an injury to your knee and you kind of feel a pop, something went wrong, and then it swells up like a balloon, about 75% of the time that's going to be an ACL tear. Other things can happen inside the knee, but that's kind of the more common things. I've seen some patients that didn't get an effusion, that's that fluid on the knee thing, but it's usually some pain. Patients that didn't get that initial big swelling, then they say, my knee just doesn't feel right. And so a lot of times you can do okay with an ACL if you're kind of walking in a straight line, but if you plant your foot and turn and you feel like those bones are kind of shifting on each other, that's a sign that you could have torn your ACL.
So what's the problem with having no ACL in your knee?
Well, again, a lot of people can do okay if you're just kind of everyday walking, but the problem is the next level of things. And so planting your foot and turning, trying to get back to playing basketball or football or soccer, or even some people hiking, working in their yard, they just can't tolerate that feeling of their knee not feeling stable. And so when that interferes with their life, that's when we start talking about doing something.
Are there other things that not having an ACL can cause, like damage to the inside of the knee or progression of a problem? Say, for example, a 50-year-old or 40-year-old person who has a normal knee otherwise has an ACL tear. Are they at risk of damaging other structures down the road or getting arthritis earlier than they would normally?
Absolutely. And at any age, about 40% of the time when you tear your ACL, you've got a risk of injuring other things. So there's meniscus damage, there's cartilage damage that can happen inside the knee. And then every time that knee shifts out of place, so if you don't get your ACL reconstructed and you're out walking in your yard and your knee shifts out of place, every time it does that, it can do more damage. So you can tear meniscus worse, you can do more cartilage damage. And we do know that patients that didn't get their ACLs reconstructed years ago before we did that surgery had accelerated arthritis in their knee. And so it can accelerate arthritis. It can cause damage to other structures inside the knee if you don't get it fixed.
So what do you do? When somebody comes in, doc, I twisted up my knee, it feels funny, it keeps shifting. What's the process of evaluating that and then making a decision about what to do?
Yeah, a lot of times you can get an idea of what's going on just from the history. So I twisted my knee, I felt a pop, and then it just wasn't right after that. An exam is always crucial. If you can examine a knee early before it's swelled up really big, you can often feel the ligament instability, and then looking for other ligament instability. So you can, again, like I said, you can damage other things inside the knee besides the ACL, but often our go-to test is going to be an MRI. Usually get an x-ray first just to make sure no fractures, nothing else going on that would be a surprise. But an MRI is going to tell me, did you tear the ACL? What's your meniscus look like? Do you have other cartilage damage? And get a better idea of where we go from there.
And then tell me kind of your thought process about how you approach the variety of people. So the younger person, athletic person, the middle-aged person, the older person, and then if you want to, let's talk, if you have any interest in this, talk about the child athlete or something like that.
Sure. Well, as you mentioned, all different age ranges can tear their ACL. I mean, so from the child or the maybe we say skeletally immature is the big doctor word for it, but essentially if your growth plates are open, that adds a different level of complexity to the surgery. And so there's some specialists in our group in TOA up in Nashville that take care of that. So that's one thing you look for. If it's somebody in the teenage years, are their growth plates open? Kind of get a feel for where they are in their growth phases to see, are they getting close to being done growing, to say we can just do a normal or regular ACL reconstruction versus doing something where we have to make sure we spare or don't injure the growth plates when we're doing surgery. So that's the young athlete. Then the more common one is our high school to collegiate athlete, and then we're going to try to figure out what all's injured from their MRI. What are their goals? What are they trying to get back to doing? And then come up with a plan for surgery. Most time at that age, your high school through 20s and 30s, most people are going to elect to have a surgery because they're going to want to stay active. Once you get in your 40s and 50s, surgery is still an option. You're starting to deal with other issues. So if you've got arthritis in your knee or other issues, is ACL surgery the right thing for you? Or if your activity level is not something that requires cutting and jumping and sprinting and those type of things, maybe you elect to not have that surgery. So it kind of depends on what was going on in the knee before the injury, and then what the patient's goals are after you've seen them.
So you've decided on surgery. Let's just assume we'll take the skeletally immature of the child out of the picture, because that's really a specialty kind of area. So that sweet spot middle age category of teenager, 16, 17 above, on up to the active person in there without a whole lot of problems.
Sure.
How do you fix it?
Yeah. So first of all, like I said, we get the MRI, kind of see what else is going on in the knee. So if it's just an ACL tear, then we reconstruct that. Again, like I said, many times there can be meniscus injury, other cartilage damage within the knee, and so those are all things we would have to kind of plan out and come up with a plan during surgery. Many times, unless there's something urgent or emergent in from the trauma, try to let the knee calm down from the injury. So kind of let the swelling go down. Try to let him get back to a more normal knee motion. Oftentimes an MCL or medial collateral ligament injury will happen as well, and try to let that heal up a little bit before surgery. And then fixing it. So fixing it requires using some sort of graft to reconstruct or make a new ACL. And then your body uses that graft as a scaffold to then fill that with cells and make a new ACL out of that. And that's what takes so long in the recovery process, is the body using that scaffold and re-strengthening it and making a new ACL out of it. There's different tissues we can use to fix the ACL. There's taking the patient's hamstring tendons as an option. Taking a piece of bone, patellar tendon bone, so a piece of bone from their kneecap, a piece of their patellar tendon, and a piece of the bone where the patellar tendon attaches into the bone, using that as a graft. And then the other is an allograft or a cadaver graft, or a graft from somebody who's died. It's been cleansed, and then we can use that. Try to avoid the cadaver graft in somebody that's younger in their teenage years, because we can see there's a higher chance of re-tear in that. So we don't, going through a big surgery already, don't want to increase our chance of redoing this. And then I talk to the patients and their family about their different graft options. The graft options will somewhat be associated with what your surgeon is comfortable with. So if they did a training where they did mostly hamstring grafts, they may offer you hamstring grafts, or the opposite for bone, patellar tendon, bone. I kind of try to find what seems to be the best graft option for that patient, for their activity level, because there's different side effects and pros and cons to each one. Long term, they both do similar. We're talking about patellar tendon versus the hamstring, but each has a little bit of pros and cons to the harvesting, the recovery, those type of things.
So when I had mine done, and this was 95, so it was a long time ago, we had one attending that was hamstring, one attending that was patellar tendon. And in looking at the mechanics and what I was interested in, I chose the patellar tendon. Because my fear at the time, and I want to understand if this is founded on anything or not, is my fear was harvesting normal tissue in the hamstring. Could that lead to a dysfunction in my hamstring down the road that could be a problem for the things I like to do at the time, which were cycling, triathlon, that kind of thing? What's your thoughts on the morbidity, if you will, or the consequence or the cons of using hamstring graft, for example?
Sure. So you are taking the tendons that attach the muscle to the bone. The benefit of a hamstring is it's a little more cosmetic, so you can take those hamstrings for the smaller incision. The downsides of it, it's variable in size. So if you have a small teenage girl who's a gymnast, you might only get a small 7mm graft, versus if you take the patellar tendon, I can take 9 or 10 millimeters every time. The long-term side effects of taking the hamstring, they actually heal up pretty well. If you were to kind of compare side to side, maybe a 5 to 10% chance of difference in strength, but it's usually not enough for you to notice. So it's a pretty good graft. I mean, and again, the only concern I have with it is the variable in size, but I use it quite often.
Yeah, good. Yeah, I also didn't like the fact that the guy who did it used a gigantic screw to tie the thing down, and so you have this big knob of a screw on your tibia, which I didn't want. So.
Yeah, and anyway. that's definitely something that's progressed over time, as well as our different fixation devices and things like that. But yeah, it used to be big metal screws that you could palpate. Even when I first started, I was doing that. So I've got patients in Murfreesboro that have those, and then come back later and take them out if there's an issue or whatever.
Now, there's always an open incision to these, but these are primarily done arthroscopically assisted, is that correct?
Correct.
So it's smaller incisions and less trauma and more direct visualization under magnification, which really makes a big difference in, I would imagine, in placing the grafts appropriately and making sure that you have the right amount of tension and such on the graft. Is that right?
Exactly. Yeah, we definitely made a lot of progress with that as well. So there's different, more specialized implants or instruments to make sure our grafts are as most accurate position as possible. And that's kind of the stuff we're tweaking. We know there's a failure rate with ACL reconstructions, trying to decrease that. And what's, is it the graft choice? Is it where our tunnels are placed? Is it our rehab, and all those type of different variables to try to make sure we're optimizing our patients' outcomes to get them back doing what they want to do.
So for the big thing for me was the rehab afterwards. That was the big key to getting a good outcome. You start off with a good operation, but then you want to do the rehab. Tell me a little bit about just your general, not the specialty case of the redo, or the super old or super young, or even cadaver versus the patient's own graft material. Tell me a little bit about your basic rehab program. What's to be expected? How long does it take for somebody to heal, rehab, and get to their new normal?
Right. Yeah, and that's one of I would say the three variables you have in recovery from an ACL surgery. So you've got how severe was the injury, what else was injured, getting the surgery done correctly, and then there's a lot on the patient's shoulders to get the rehab done right. There's a lot of work that goes into whichever graft you use, whatever all has to be done at the time of surgery, the recovery, the therapy, really, you put it back on the patient's shoulders to recover from that. So early on, you're trying to get the knee to calm down from the surgery and work on range of motion. So usually you're in a big brace that kind of goes from your hip down to your ankle, and then depending on if you had to have any meniscus work or other procedures would determine when you would be allowed to put full weight on your leg. So 2 to 4 weeks, kind of depending on what all was done inside the knee. First working on range of motion, then adding in strengthening, and then often patients do pretty well after that, and there's this sort of window where their knee is doing good, it's moving well, they're walking on it pretty well, they feel like they could do more on it, and I'm having to put the brakes on them to slow them down. And so try to give about 3 months before you do jogging, and then usually it's 5 or 6 months before full speed running, jumping, cutting, back to skiing, those type of things. And so that's just how long it takes the body to take that, again, like I said, take that scaffold of tissue and make a new ACL out of it. And usually, especially my teenagers, they're ready to go much earlier from their standpoint, but I'm having to slow them down because we don't want them to start all this over again.
Right. The last thing you want is a re-tear too early because the graft hasn't become incorporated yet.
Right.
Now, you always hear on ESPN and whatnot that, oh, this is a season-ending injury for the NFL ball player, and it always seems to be a year that they turn around. I would imagine that while, yes, you're dealing with the biology of the healing of the skin, the biology of the healing of the graft, the reconstitution of the graft, but I would think that the high-level athlete, the added length of time is because they feel their bodies differently than you or I do.
Right.
They have a much more sensitive interaction with the earth.
Right.
And that's where a lot of that really is coming into play. It's not waiting for it to heal, it's waiting for them to get their their mobility back that they don't have to think about.
Yeah.
Is that about right?
Yeah, I tell them regaining trust in the knee. Because the last
Trust
time,
in the knee, yeah, that's a good point.
Last time they played football or basketball or soccer, they tore their ACL.
Yeah.
And so now I'm saying, all right, great, go out there and go back to doing what you were doing, but they've got to, get the trust back in their knee. And that's why I tell them, especially if we've got a deadline of a season starting up right away, when we're within 6 months of a recovery, I say, put that on my shoulders. Don't go out there and feel like you have to prove to anyone, because nobody else on your team has been through what you've been through over the past 6 months. But it might take you, some people it takes 6 months, some people take 7, 8 months, and that's okay. So it's just kind of retraining and re-strengthening, because that's a whole other level of getting to Division I or high level athlete, high level college, or high school athletics is more so than just you and I walking through the office. And so trying to get to that level, it takes another level of trust, and it takes planning on that foot and turning and saying, oh, it didn't come out of place that time, or whatever, so it just takes them a while.
So there's a lot of, particularly the high performance athlete that you deal with, such as at MTSU and others, it really is, part of it is some psychology too.
Right.
Where you're having to help them understand the confidence in their body, so they don't have to think about it, they can think about where they're going next rather than, oh my God, what if?
Right.
Yeah.
Because I can tell them over and over again, your knee looks great, but until they've tried it out, until they, until they know inside one of the things we'll do, some patients will wear a brace for even up to a year after the surgery, just to kind of give them, it doesn't necessarily decrease re-injury, but it seems to give them a little confidence in their knee. So that's one thing we'll do kind of long term.
So tell me a little bit about the bad things with regard to ACL reconstruction. We always have to talk about complications or risks. When somebody's facing the decision of whether or not they're going to have surgery, what kind of risks does the surgery potentially pose to people?
Sure. Well, anytime you go to the operating room, you worry about infection. So, and especially in our athletes that are in locker rooms and they're, around patients with staff and things like that, you worry about that. So, they get antibiotics during surgery to decrease the risk of infection, those type of things. You talked a little bit about, what are our risks of taking the hamstring or even the patellar tendon. So some people will have pain associated with taking a graft. And so whether that's some anterior knee pain from taking the patellar tendon or some arthritis behind the kneecap, we know there's a little bit of increased risk of that if you take the patellar tendon. And another common complaint after the patellar tendon is it just doesn't feel right for me to kneel on my knee. So, so those are some things.
Now that took a couple of years for me
yeah.
to feel better. It felt like I was kneeling on a hole.
Yeah. Then there's a re-tear rate. It's about 5%. We'd love to make it 0, but realistically it's about 5%. Then we talked about other things might have had to be dealt with at the time of surgery. So if you had your meniscus fixed, it could re-tear. There's hardware in there to fix meniscus and screws and things. Sometimes people have pain from that and want that removed. I'm working inside the knee and I can see everything through the scope, but some of the things are passing outside the knee, so there's risk of damaging blood vessels, nerves, tendons, those type of things. A common one that we deal with early is range of motion. So sometimes it's just difficult to get all your motion back after an ACL reconstruction, and so sometimes you don't get quite the same bend that you had before on that other knee, and sometimes it takes extra procedures to get that motion. You got a few patients that just get really stiff, and you have to deal with that. Pain down the road. We know whether you have your ACL reconstructed or not. From tearing your ACL, your risk of arthritis increases in your knee, and so we hope that we're slowing that down by fixing meniscus and reconstructing your ACL. But down the road, that's a risk.
We can't take away the fact that you had an injury
right.
to your joint, and
right.
there are always consequences, even if you don't have surgery or do have surgery and everything's put back together. That joint has been injured.
Right.
Yeah. So one of the things that has really come about since I was in training, and is really interesting to me, I'd like you to touch on, is the apparent differences between males and females, and why it seems like, now granted the data that came about when I was younger was male centric.
Right.
There are many more high level female athletes these days than there were 50 years ago. But tell me what's the deal with men versus women, why women are different than men with regard to the ACL?
Sure. few different anatomic things we see that are different. Women in general are a little bit more knock-kneed than men, and so that can we think that may be somewhat of a predisposition to tearing your ACL. Also, the notch or the space in the middle of the knee where the ACL sits is usually more narrow in women, and we think maybe that could cause some impingement or maybe cause the bone to push on the on the ACL itself and maybe increase a chance of tear there. There were some studies for a while looking at hormonal differences, kind of goes back and forth whether or not that's a big issue or not. And then another thing that we've seen in women and female athletes is they really respond well, or we found that we can decrease ACL tears by kind of training how they land, and that seems to be a little bit more land from a basketball is kind of what I'm thinking about, right. But kind of preventative therapy seems to work really well in women, and so in our female athletes. And so just kind of changing how we land. So landing, we know that if you land with the knee in a more extended position rather than a flexed position, then that's going to put more stress on the structures inside the joint. Whether if your knee's bent a little bit, then you can take some of that stress through your muscles. Also kind of landing more on your toes rather than on your heel seems to again allow your body to sort of absorb the impact of the fall rather than that going through your joint itself. And those are some of the things that we work on, kind of training our volleyball players and our soccer players and our basketball players, especially that are females, kind of retraining how we land. Sometimes you can't control it when you're out there on a game and somebody else is under you when you're coming down from a layup or whatever, but in general, those are some things we can do to help decrease that.
So stopping is always harder on our body anyway.
Exactly, exactly.
Yeah. So what else? We're going to kind of wrap it up. I think we've done a pretty good job about, general overview. What are things we haven't touched that you'd like to touch? What are some pieces of advice you have for people, and any pearls of wisdom you might have?
Sure. I think we've covered most things from an ACL reconstruction standpoint. I think it's important for you to, find a position that you're comfortable with, and come with questions, and have realistic expectations. I mean, our goal is to get everyone back to the level that they were at before, but realistically, 85 to 90% get back to the level that they were at before after an ACL reconstruction. Doing your homework for doing your rehab and all those type of things after surgery. I think those are kind of the main things. The only concern I have with saying go out and get your answers is if you go to Dr. Google, he may give you a different answer than what you're going to get from your.
Well, I was going to ask you that, because so much these days is stem cell this and, and regenerative medicine that. Is there anything on the horizon that would either augment, help reconstruction to become better, or replace or mitigate the need for any reconstruction? Is there anything that's realistically out there at this point?
Well, I think some things that we're working on to see are they beneficial. Some patients have, rather than tearing the ligament in the middle, they can just pull it off of the bone. And some people are working on repairing the ACL rather than reconstructing it. And so that's something that's out there to see, can I put your native tissue back together rather than taking something from somewhere else and reconstructing that. And so there, on some select patients, that seems to be something that we're seeing could be beneficial. Could you have a little higher re-tear rate with that? That's kind of what we're looking at. Then there's the subset of patients that have a partial tear. So we know that the ACL has two different bundles, and some people can tear just one bundle but not both. And so then what do you do with that patient? Do you just sacrifice their other bundle that's still good and just do a regular ACL reconstruction, or do you just try to reconstruct a portion of that? And so those are some of the things that we're kind of looking at now to see what do you do with that patient that's a little bit of an outlier. And then as for adjunctive things to try to get things to heal up faster, I don't think we've found the perfect thing, whether it's a stem cell or a PRP injection or something like that, to say for sure that's going to heal your ACL rather than a surgery. The problem with the ACL tear is the ACL tears within the joint, and the joint fluid inhibits healing of things. And so even if you inject something that potentially could allow things to heal, for whatever reason, that joint fluid milieu just doesn't allow for healing like it does. And so that's why we're operating on most of these. But could a well-done ACL reconstruction with a PRP or a stem cell injection or one of those partial ones, could that go from a 5% to a 2% re-tear rate? And that's our goal,
Right.
kind of. So a lot of that
We'll
stuff is
never
still
make
out there.
zero, but
Yeah.
you want to get as close as possible. Yeah, I was just going to mention that some people ask, gosh, can't you just sew the two pieces together? And the reason why is, number one, it's inside the joint with the joint fluid, which is counterproductive to healing.
Yeah.
And number two, the ACL doesn't have a terrifically good blood supply in the middle of its substance, but that at the ends where you tear it off the bone, there's actually better blood supply there, and that's where the hope is that maybe you can repair some of those in that area. So
you tear it in the middle, it's like trying to put two mop ends together.
Right,
It's just
exactly.
you just don't have good tissue to hold suture and
Exactly.
stuff. So then we reconstruct it.
Well, I can tell you, having had it done a gazillion years ago, it was great, and it was hard work, but it was worth it. And I've been able to cycle, I've been able to be a triathlon, I've run several marathons since I tore my ACL. So now I have other problems. I'm 59, so I've got arthritis in my knee. I've torn my meniscus twice since I tore my ACL, but it's definitely something that you need to look into. And I think we've got good solutions surgically that are relatively straightforward, relatively easy to get over, with a high success rate and a pretty low downside.
Yeah, and that's our goal. That's what I tell any of my patients, is to get you back to doing what you wanted to do, whether it's playing soccer or cycling or somewhere in between. That's our goal, is to get you back to what you were doing before and have a knee that you enjoy, and you don't have to worry about it when you're back out on the field or hiking or working in your yard or whatever level of activity you're trying to get back to. But keeping people active and enjoying the things they want to do, that's the goal of any of our surgeries, really.
So other than MTSU, do you cover any other schools locally?
Yeah, I'm usually on the sideline for either Riverdale or Blackman, but all of us here in Rutherford County, we kind of make sure somebody's on the sideline for our home games so I've Siegel, Oakland, all those, I've been there, been on any of those sidelines, here and there over the years. So yeah, I really enjoyed it. It's something that's kind of my passion. It's kind of my way to get back to the community, and enjoy seeing those guys that maybe I worked on the year before are back out there playing again. And it's just something fun.
That'd be awesome, man.
Yeah.
Then you see your friends' kids playing too.
Yeah, that's right.
That's
yeah.
awesome. That's awesome. Okay, well, I think we'll wrap it up. Russell, thank you. That was awesome.
Appreciate
that was really
it.
good. Please come back anytime you'd like. If you have other topics you'd like to talk about, they want to hear it.
Great.
Again, Russell McKissick, he's primarily in our Murfreesboro office. Do you go anywhere else?
Nope.
Okay. So he's in our Murfreesboro office. TOA.com is the place to look for information about us, about the physicians, about our services, about our locations. You can make appointments online. We even still do telemedicine periodically if that's your flavor. But go to TOA.com and get the information that you need. Other than that, I think we're done here. Thank you again.
Yeah.
Go out there, live your best life. Have a great week, guys.
Thank y'all.